Hello, and welcome to the APAC Recap of CAPP 24. My name is Laura Ross, President of the Academy of PAs in Cardiology, and I'm thrilled to have Viet La here to tell us a little bit more about his experience at our inaugural CAPP conference. Viet, welcome, and thank you for being here today. Tell me a little bit about what you presented at the CAPP conference in October.
Yeah, I had a few opportunities actually to present on a few things. Lipids, of course, being one of them. I did present a little bit on metabolic associated dysfunction, liver disease, so MASLD and MASH. And then finally, updated folks on the chest pain guidelines. But I think today we'll probably focus a little bit more on the lipid side of things.
You were the jack of all trades at that conference. It was so fun to hear you speak, just a wealth of knowledge with your background, not only in cardiology, but in research as well. So, Viet, tell our members, what did you present at CAP that you think PAs and nurse practitioners could start doing today and implement from some of the information you presented?
Yeah, I mean, I think in light of multiple different guidelines coming forward over the years, I think that's the hardest is really kind of putting them all together and like, what can I do now? So one of the things that I leaned on is the 2022 expert consensus decision pathway with non-statins, and really it leverages the eligibility for folks for lipid lowering, right? And so I think the main thing you can recognize actually amongst cardiology practitioners is that there is a differentiation between stable ASCVD, meaning if you've had a heart attack or stroke, peripheral arterial disease, and very high risk ASCVD. So folks who really are at the highest risk of having another event, whether that's, they survive two events, or maybe they have coronary disease and two risk factors. So that's really a huge takeaway here is that the majority of our patients actually meet very high risk ASCVD. I challenge you to find a coronary disease patient that doesn't have hypertension and CKD or diabetes and hypertension. And that meets the guideline. What that LDL cholesterol goal is less than 55. It's not less than 70, that's for stable, but very high risk ASCVD is less than 55. And so that's one thing that you can do immediately is recategorize your patients to very high risk ASCVD. And then, it should be beyond the statins, right? We have non-statin therapy. So I discussed being able to use Nexlizet or bempedoic acid plus ezetimibe, and then really leveraging the PCSK9 interfering therapies.
Love it, Viet. That's fantastic points. I think well taken there. Next question. What's an unknown or little known fact on some of the topics you presented that you want people to take home if they weren't
Yeah,
able to
so
attend CAP?
yeah, that's fantastic. I mean, it's so funny because a lot of, and you probably run into this as well in our preventive cardiology clinics, is the referral is for statin intolerance. And it's real, okay? Let me not downplay that statin intolerance is something that people do experience. And myalgias are really life-altering for folks, like quality of life goes down. But the good news is really a little unknown or little known secret is that there is a statin called pitavastatin. And this was developed amongst the Japanese population, actually by a Japanese pharmaceutical company. And pitavastatin comes in 1, 2, and 4 milligram doses. Really, what you find curious about this is that for those individuals that have tried multiple statins, there's nearly a 75 to 85% success rate in reinitiating statin as pitavastatin. And the brands that are currently available are Livalo and Zypitamag. But honestly, you can come back to it. It's very hard to reduce LDL cholesterol in folks when you lose a large part of LDL cholesterol lowering, like if you can't use a statin. So here, pitavastatin at 2 and 4 milligrams actually reduce anywhere from 30 to 49%. And then you can add ezetimibe and bempedoic acid. But that's really a nice little secret there that exists now and you can leverage.
I love that's a great pearl. And I think because it's not generic, it's not in our tool chest a lot that we think about, but for those of us who work a lot with statin intolerant patients, it's a great avenue because you get all the other benefits of statins, and explaining how it's a little bit different can help. All right, Viet, last question to our immediate past president of APAC and lipid guru. What's the newest guideline that's come out in regards to your topic?
So I love saying things in threes. And I started out with this. It's the 2022 Expert Consensus Decision Pathway
Mhm.
in the use of non-statin therapies. And so that is the latest guideline. We'll probably see an update here soon from ACC/AHA. Let me not forget that National Lipid Association did discuss Lp(a) in their statement and guideline. But for those of us that really are trying to manage the bulk of everyone before drawing an Lp(a), the 2022 Expert Consensus Decision Pathway is nice. It really does update utilization of non-statin therapies and introduces that very high risk ASCVD category.
Yeah. And I like to highlight the risk enhancing factors as well, just to keep in mind, especially for women, premature menopause and preeclampsia are questions that were maybe routinely asked and recognized as a risk factor. So I think you did just a fabulous job at CAPP, and thank you for recapping some of those pearls here. It'd be always good to talk to you. Thanks so much.
Thank you. Thank you again, Laura, for giving me this opportunity to be part of the APAC Recap. And as a cardiology provider, we hope to see you there next year. If you want to learn more, you can go to our website, the APAC website, cardiologypa.org, or CAPP, CAPPlive.com.
Thanks everyone for tuning in to this episode of the APAC Recap. You can find this episode and more at HCPLive and on YouTube. See you next time.